generous when they suggested some of the things he just told you about, and even I enjoy hearing every word of it. One thing Professor Stroud did not say was that we have a relationship with Václav Klaus, who is the president of the Czech Republic, and until recently he was also the head of the European Union. And I was over in the Czech Republic a year or so ago, and they asked me to speak for a group of elderly people. They didn't speak English, and I didn't speak Czech. So they had a translator there, and they said, this is what's going to happen. You're going to speak, and then you stop, and then I translate. You speak and stop, and I translate. So well, I think I can do that, but how will I know when to stop? He said, well, I'll tell you. So I got up and I began talking. I looked his way, and he didn't say anything. I kept on talking. Still didn't say anything. I must have gone on for 15 minutes. And then he jumped up and said, stop. And then he said something in Czech that I didn't really understand, but could have been more than a sentence. And there was some polite applause. And he said, now you may continue. So I began talking again, and he looked his way. He didn't say anything, and I went on and on. I must have gone on for another 15 minutes. And then he said, stop. And then he got up and said something in Czech again. It could have been more than a sentence, just a few words, actually. And then he said, now you may continue. So I got through the last third of my speech, and he got up and he again said a few words in Czech, and then this time the applause was really quite appreciative. And as people were pouring out of the room, I sort of called him aside and I said, like, if you don't mind my asking, how were you able to summarize what I had to say so succinctly, so economically? I was very impressed with that. He said, oh, that was easy. He said, after the first third of your speech, I said, you haven't said anything yet. Then after your second lap around the topic, I said, still nothing to report, but he's almost done. And at the end, I said, it's over. If you Google the John Goodman Health Policy blog, you're going to discover two things. First, this is about the only health policy blog on the internet that approaches healthcare from an economic point of view. At our blog, we believe that the reason we're having so many problems in healthcare is because people face perverse economic incentives. And when they act on those incentives, they make costs higher, quality lower, access more difficult than otherwise would have been the case. And we believe we're not going to solve these problems unless we get the incentives right. The second thing you're going to discover is that our blog is the only blog of any persuasive health policy that has a sense of humor. I don't know what it is about the film I'm in, but it's dominated by the sours. And not only do they not have a sense of humor, they don't always know when I'm joking, and it's got me in trouble, including with people like Goodman, who writes for the New York Times. Has no sense of humor whatsoever. So we created on our blog this yellow yield sign, which is for the humor challenge. And when they see that, it says satire alert. And that's to alert them not to take everything seriously on that particular blog post. But we feel like if we don't make people smile at least once a day at our blog, we're not doing our job. And we'll do things like we had a post the other day on Obamacare and HMOs that said that Obamacare is going to push you and HMOs are going to ration your health care. And underneath it, we got from YouTube Aretha Franklin singing Say a Little Prayer for You. And then we had another post the other day on end of life care. We had Bob Dylan singing Knock on Heaven's Door. And then we had this really neat exchange between the doctors and the insurance guys, and it went back and forth, for probably 50 or 60 comments. And finance, one doctor said, he just got so fed up, he said, your insurance guys are killing us with all your regulations, all your rules. And I thought that was kind of interesting. So I reposted some of those comments back on the blog, and underneath it I had Leslie Gore singing, You Cry Too If It Happened to You. Probably, well, sometimes we're accused of being insensitive and irreverent. I guess the worst thing we did was about 2 years ago. This man walks into the emergency room of Parkland Hospital in Dallas. He waits 19 hours and dies before he ever saw a doctor. And we thought this was a real tragedy, and we also thought it probably happened in a lot of other cities. So we posted a little post about it. But underneath it, we had Lionel Richie singing all night long. And that probably was when I talk, I usually have my cell phone because you never know the kind of words you when you're talking. That wasn't serious. What is serious is, did you know there are more cell phones in the United States than there are people? Even the panhandler on the street corner probably has a cell phone, but he probably doesn't have very good access to health care. If something goes wrong with my cell phone, there are dozens of repair shops in Dallas that I can walk into without any appointment at all, and I can get high quality, low cost service at the drop of a hat. There are even shops that will send a repair person to my condo and repair my iPhone in my home. There is a chain of these repair shops called Eye Hospital, and the employees are called Eye Doctors. And it's pretty good service. But if something happens to my body, did you know that the average wait in the United States for a new patient to see a doctor is now 3 weeks? In Boston, where we're told they have universal coverage, the wait is 2 months. Amazingly, 1 out of every 5 people who enters a hospital emergency room leaves without ever seeing a doctor just because they get tired of waiting. And so my question to you is, why is the market so kind to my iPhone and so mean to me? And the answer, I think, is that this iPhone is bought and sold, produced, and repaired in real markets, in real prices, where entrepreneurs know that they can get very wealthy if they can satisfy our needs. But over in the healthcare sector, we have so suppressed the market for decade after decade after decade that no one in healthcare ever sees a real price for anything. No patient, no doctor, no employee, no employer. Basically, in the United States, we're paying for healthcare with time and not with money. We pay for healthcare mainly in the United States the same way they pay for it in Canada or Britain or all over Europe. A lot of people would like to think that our system is really different from the national health insurance schemes of other countries, but in fact, we're very much the same. In all these countries, the main barrier to care is not money, it's not price. The main barriers to care are non-price barriers. And what do I mean by that? How long does it take you on the telephone to get someone to give you an appointment with a doctor? How many days do you have to wait before you get to see that doctor? How long does it take you to get from your home to the doctor's office? Once you get there, how long do you have to wait in the waiting room before you see the doctor? Those are all non-price barriers to care. And there's lots and lots of evidence that those non-price barriers are more important than price. They're a bigger deterrent to care than price, even for low-income people. 3 quick studies I want to tell you about. One by the Center for Health Systems Change last year. They went out and observed that even though we're in very bad economic times, we haven't recovered from the worst recession in our lifetimes, and yet unmet health care needs are actually down. That's when we survey people and ask, do you have an unmet health care need? Fewer people are saying that now than before the recession started. And so the first question for the researchers is, well, why is that? And the answer seems to be that in these bad economic times, a lot of people with insurance, even though they have insurance, are being more careful, more conservative about their consumption of health care. They're putting off the marginal procedures that they think they can put off. And so they're going to the doctor less often, and what this is doing is it's freeing up resources. So people who are uninsured find it now easier to go to the doctor. All those non-price barriers, all those waiting times have come down. So uninsured people are finding it easier to get to see the doctor. Interestingly, over this period of time, the price of health care has not changed at all. Throughout the recession, the price of all the health care you're buying is pretty much the same. It's the non-price barriers that are coming down and opening up the market, especially for low and uninsured people. Second study, this comes from North Carolina. They're running out of money in their Medicaid program. They were giving people on Medicaid a 90-day prescription and charging them $1. And they said, look, we can't afford to do that anymore, so now we're going to charge you $3 per prescription, plus you can only have 30 days at a time. So what does that do? It triples the money price of care, but it also triples the time price, because now these folks have to make 3 trips to the pharmacy instead of 1 to get the same number of pills. And what the researchers found is that tripling of the time price of care was a greater deterrent than the tripling of the money price, and these are poor people on Medicaid. Third study, really interesting study of the CHIP program, which is sort of Medicaid for children. And you have to be low income to qualify for it. What they discovered was that enrolling children in the CHIP program did not result in more doctor visits, did not result in more health care. But what does result in more health care is when you pay the doctors a higher fee. Pay the doctors more, and they're more willing, more ready, more eager to see this group of patients. And yet we make it illegal all across the country for parents of these children to take money out of their own pocket and add to the government's rate. Not only is it illegal, it's probably criminal if they do it, or if the doctor accepts the money. Now in this country today, there are about 50 million people on food stamps. Everybody know what the food stamp program is? Heard of that? Okay. People on food stamps can walk into any supermarket that you and I can walk into. They can buy almost any product that you and I can buy, and they're paying the same price that you and I pay. When they get to the checkout counter, they put their food stamps down, they put cash on top of it if they need to, and they consummate their transaction. You almost never, ever hear it said that low-income people have a lack of access to supermarkets, right? I mean, the worst thing that can happen is they have to get on a bus and go a distance to get to the supermarket. But there aren't any supermarkets that say we don't accept people who want to pay with food stamps. No, none in the country. Now, over in the Medicaid program, which is again our health insurance for low-income people, in that program, there are another 50 million people. In fact, basically, they're the same people who are on the food stamp program. And what is the biggest problem people on Medicaid have is finding a doctor who will see them. Now, I was in Boston a year or so ago, and as I often do when I'm in a different city, I struck up a conversation with a cab driver, a woman. She told me she was on Mass Health, which is a Massachusetts Medicaid program. I said, well, how's it working? She said, well, she said, I guess it's okay, but I'm having a real hard time finding a doctor who will see me. And I said, well, tell me about that. She said, well, I went down a list of 20 names before I found a doctor who would take me. And I said, were you going down the yellow pages? She said, no, I was going down the list that Medicaid gave me. Okay, those are the problems that people have, and not just in Boston, all across the country, if they're on this program for low-income people. You know, all across the country, there's another kind of way that people are getting health care. You have a CVS pharmacy that's all the way to campus. They have minute clinics. Have you been to a minute clinic? You know what they are? When you see these clinics at CVS pharmacy, you see a different kind of clinic at Walmart, you see them in shopping malls. As the name minute clinic implies, it means they know your time is valuable as well as your money. It's low-cost care. It's high-quality care. In fact, not only is it high quality, but the nurses delivering care in these clinics actually are more consistently following protocols than traditional family doctors. It's affordable. It's quick. It's accessible. And yet, in Dallas, Texas, the price that's charged by the minute clinic, say for a sore throat or earache, is about $75. Medicaid pays half that much. But unlike the food stamp program, we make it illegal for low-income people to take money out of their pocket, add to the Medicaid rate, and pay the market price for minute clinic care. And since they can't do that, they're closed off from the minute clinic. So what do? They have to go to community health centers in places like the Parkland Hospital Emergency Room, which is a safety net hospital, and where they wait, and they're not typically going to wait 90 hours, but waits of 4, 5, and 6 hours at the Parkland Hospital Emergency Room are not unusual at all. If you walked in there with a migraine headache, you could easily wait 8 hours before anybody sees you. Now, if you walk in and you're bleeding all over the floor, they're going to look after you. But if you're not bleeding all over the floor, get prepared for a rather lengthy wait. We could greatly expand health care for low-income people in this country if we would just do one simple thing: allow poor people to buy health care the way they buy food. Over the food market, we don't have the problem of access at all. Over the healthcare market, I read the other day that 1 out of every 3 doctors is not accepting any new Medicaid patients. So we have a real problem of access to healthcare, especially for low-income people. No problem of access to supermarkets. So if we want to begin to deal with our problems, the first thing we have to do is liberate the patients. We have to take these silly rules and regulations, push them out of the way, and literally liberate them in the marketplace. The second thing we have to do is we have to liberate the doctors. The doctors are the only professionals in our society who are not free to repackage and reprice the services that they offer to the market. Every other professional, the lawyers, the accountants, the engineers, the architects, if demand changes, if technology changes, they can change what they're offering, they can change the price they're charging. Doctors are not free to do that. Doctors are slaves to a third-party payment system. By third-party payers, I mean employers, insurance companies, and government. And they're literally dictating the prices they will pay to the doctors, and they're dictating what they'll pay for and what they won't pay for. And so doctors have to respond to that. Now let me give you an example. About, I don't know, almost a century ago, most of the other professionals discovered the telephone. A telephone at that time. But they discovered it's a very useful instrument for talking with clients. Everybody uses the telephone except the doctor. The doctor doesn't call me on the phone and talk to me about any health problem. He wants me to come to his office. He wants a face-to-face meeting. Why is that? Anybody know? He doesn't get paid. Who said that? He said the doctor doesn't get paid, and that's exactly the right answer. You know, Medicare, which is the government program for the elderly, has 7,500 tasks that will pay doctors to do. 7,500 things that doctors do and get paid for. But unfortunately, the telephone is not on the list. All right? Now, doctors are getting squeezed. Nobody, all the third-party payer bureaucracies are trying to push their fees down. The doctor doesn't have time to spend very many non-billable hours. He almost has to do things that he can bill for. We get to the end of the 20th century and everybody discovers email, right? I have a legal problem, or I had one, and my lawyer talked to me by phone, sometimes face-to-face, sometimes other times by email. She bills by time. And so we do what's efficient. If we need the face-to-face meeting, we do it. If we need to talk, we do that. If email will suffice, we do it by email. That's the way I deal with my accountant. That's the way I deal with a lawyer. Everybody's emailing everybody these days. Even the corner of a liquor store emails me. They have a bottle of wine and think I want it. But my doctor's not emailing me. By the way, the Minute Clinic does. In early September, the Minute Clinic emailed me and said school's about to start and the kids got their vaccination. And then I got another email from them just the other day saying it's flu shot time. You got your flu shot yet? But I don't get emails from my doctor. Why is that? You were so good last time. You know? This is an easy pop quiz, folks. You just get that answer, keep repeating, you're going to make A+ on this exam. Of the 7,500 tasks that Medicare pays doctors to do, email is not on that list. And by the way, anytime you pay any professional by task, whether it's a lawyer, or accountant, or engineer, you're going to write down all the things you're going to pay for. By implication, everything you didn't write down is something you're not going to pay for. And it's almost guaranteed that you're going to leave important things off the list because you cannot possibly think of all the things you're going to want that professional to do for you. And that's what's happening in healthcare. You go to a doctor and he prescribes medication for you, but he doesn't know what it costs. And even if he does know what it costs, he doesn't know if there's a therapeutic substitute or a generic substitute. And even if he knows about the substitutes, he doesn't know what they cost. Or even if he kind of knows what these things cost, he does not know where you can get the best price on the pills you need in the neighborhood where you live. And why is it that the doctor's not telling you these things? Why is it he doesn't know these things? Because again, Medicare doesn't pay the doctor to know these things. Now our office, we've actually gotten on the internet and looked at prices nationally, and we've discovered that most people can actually cut their cost of prescription drugs in half if they become smart shoppers. But we also discovered that you don't do this in an instant. It's time consuming, it's burdensome, and I can understand why doctors aren't doing it. But of all the people in the healthcare system, who would be the best person to know this information? It would be the doctor, if only he were allowed to charge it and we were allowed to pay for it. After all, it's something valuable to us. I'll give you one more example. A mother takes her diabetic child to the the emergency room, it's a health problem, doctors deal with a child. If they would just spend 30 more minutes, they could teach that mother how to manage the child's diabetes in the home. There are lots of health conditions patients can manage themselves, or children's health conditions that parents can manage, but they need some kind of training to know how to do it. Here is another activity that's not on the list of Medicare's 7,500 things that it will pay for. And so here's another thing that would be a great investment in lowering healthcare costs and improving quality that's simply not getting done. Have any of you ever heard of Dr. Jeffrey Brenner? Hot spots? Any of you read the New Yorker? No? Not on your reading list? All right. Camden, New Jersey is supposed to be the lowest income county in the whole country, as far as I know. If you live in Camden, New Jersey, you don't have private insurance. You're either on Medicare for the elderly or on Medicaid for poor people, or you're probably uninsured. So Dr. Jeffrey Brenner is living there, and he's an entrepreneur, he's a researcher, and he begins going through the list of hospital patients, and he discovers that 1% of all the people living in Camden are generating 30% of all the costs for the hospital. And he goes down the list and he picks out one of the worst cases. This is a man who weighs more than 600 pounds. He's a diabetic. He's an alcoholic. He's on drugs. He's pretty much of a mess. He spends half the year in the hospital. And when he's not in the hospital, he's abusing himself. So Brenner takes this man under his wing, and he gets him off the alcohol, gets him off the drugs, and he enrolls him in Alcoholics Anonymous. He discovers this man's religious, so he gets him to start going to church, and gets him to start taking the medications he really needs to take, signs him up for some welfare programs so he can have some financial stability in his life. And pretty soon this man is not going in the hospital anymore. And since he's not going to the hospital anymore, his total health care costs start going down, down, down. And that experiment worked so well that the Brenner actually set up a clinic, and he has some colleagues, and he started doing that with more patients. Brenner tells me that he can drive down the streets of Camden and point to whole buildings and tell you how much that entire building is costing Medicare and Medicaid. So, Brenner was on the phone with me the other day, and I was asking him how all this works. And he said he estimates he's literally saving millions of dollars for Medicare. He's literally saving millions of dollars for Medicaid. Here's my question to you. For all these millions of dollars that he's saving the government, how much do you think the government gives him back in return? Anybody want to guess? Zero. Who said zero? Okay, you got an A on that. Medicare gives him nothing for all the dollars he's saving them. Medicaid gives him nothing. The only way he's able to fund his clinic is he went to the private marketplace and got some foundation money. It's all private money. Nothing's coming from the government. So at my blog, I said, we ought to allow Jeffrey Brenner to become a millionaire. It's in our self-interest. We ought to say to Brenner, look, Brenner, for every dollar you're saving the government, which means that you're saving us as taxpayers, we're going to be willing to let you keep 25 cents. And then what we ought to do is tell every other doctor in America what we've done. We ought to say, if you want to be paid in a different way, okay, if you're performing services that are not on our list of things we pay for, because see, the problem with Brenner is most of what he was doing was social work. And social work is something else that's not on the list of 7,500 things that Medicare basically pays for. And so what we need to say to all the doctors in America is, if you want to do something that's not on our list, you want to be paid in a different way, we'll pay you in a different way, provided that you're saving the taxpayers' money and you're improving the quality of care for the patients. And if you're doing that, you tell us how you want to be paid. Instead of Washington telling doctors what it will and won't pay for, let's let the doctors tell Washington what they can do and what they can do it for and why it will lower costs and improve quality. That's what I mean by liberating the doctors. Now, the third thing we have to do is liberate entrepreneurs. That CVS pharmacy, that Minute Clinic that I referred to a moment ago, that was an entrepreneurial activity. That was outside the third-party payer system. That service came into existence to help people who pay with cash. who do not have health insurance. You know, I'm often asked, can a free market really work for health care? And my answer is that wherever there are no third-party payers, wherever there's no Blue Cross, wherever there's no government paying bills, wherever there's no employer paying bills, health markets work really, really well. But the walk-in clinics are one example. Cosmetic surgery is another example. Just looking around the room, I would guess that most of you don't know anything about the market for cosmetic surgery, all right? But given another 20 years, a lot of you will get really interested in what we do for you. Here's a market where there are no insurance. You know, if you want an eyelid, facelift, you pay with cash. You pay with your own money. This is a market where the number of procedures over the last 15 years has grown 600%. All kinds of technological change, the type that we're told really increases costs for every other kind of surgery. And yet in this market, the real price of cosmetic surgery has gone down over the last 15 years, even as the real price of just about every other kind of surgery is going up. And not only is it going up, it's going up at twice the rate of growth of our income. LASIK surgery. Give it another 20 years and you'll learn about this too. It's another market where there's no insurance. You pay with your own money. We have price competition. We have quality competition. Just like in the cosmetic surgery market, you have package prices. You ever go to a doctor's office and ask what something costs? And the doctor typically doesn't know. You ask the nurse, she doesn't know either. And you look around and you don't see any prices posted on any wall. You can't find prices in any book. This is the way doctors function, right? Hospitals are even worse. Well, in the markets where you don't have insurance, it's always easy to find out about prices. At the Minute Clinic, they've got their prices on the wall, and you can see when you walk in exactly what you pay for each procedure. Cosmetic surgery, you get a package price in advance. It covers the entire procedure, the doctor, the nurse, and the facility. It's one number, one price for the entire package. LASIK surgery, same thing. When there's no price transparency, that tells you that in the marketplace, these guys are not competing on price. And I'll tell you something, when they don't compete on price, they don't compete on quality either. We have a booming international market, what's called medical tourism. You want to get on a plane, fly to India, or Singapore, or Thailand, you're going to find that you can get just about every elective surgery procedure that you can get in the United States. The doctors there are trained, board certified in America. It's very high quality. They compete on price and give you package prices. They're about half what you pay in the United States. They compete on quality. Most hospitals in this country, you can't even find out information about the quality of their services. Over in India, they post it online. They say for this particular procedure, here's our mortality rate. Here's our infection rate. Here's our readmission rate. By the way, here's what those rates are at the Cleveland Clinic in the United States, the Mayo Clinic in the United States. When a hospital does that, you know it's competing on quality. I'll tell you something else that most people